But it started. It started. And now there are several experiences with this tricuspid repair, and we are doing this sort of repair. We love screws in my place, so we put a screw somewhere in the tricuspid annulus, then we put a band, we pull on the band, and fixate the band by a big stent in the vertebra. It's just a joke. It's very preliminary, 10 to 12 patients, but it's already started. So we have to be good doctors, good imagers, good interventionists, but we have also to set the standards, and the first standards were published recently in European Heart Journal and JACC with Greg Stone clinical trial design principle, and we have also to perform studies when we don't know. And we just discussed with Dr. Рафаели, there are two big studies in patients with secondary. Because I told you the surgical colleagues, they were unable to show us if it is useful to treat this patient by fixing the MR. We want to go a little bit further with the devices, and we want to run this study, cohort, almost finished. They are very good around different colleagues. And we have the French one, slowly, but it is going. Patients with severe mitral regurg, patients who are sick, and patients who are very sick with heart failure hospitalization recently, terrible ventricle, and we are measuring outcome, either heart failure hospitalization for the US colleagues or death or hospitalization for us. The outcome will be, these studies will be finished, and probably the first one to be published will be this one, end of 2017, early 2018. A study will be published 1 year after, but please always do good studies. There is another study we are running with Francesco Maizano. It's a study in high-risk degenerative MR, but we are going to start the study, it's not done. But now, before ending, I'd like to be a bit sad. It's good to speak about theory, it's good to show images, but we have economy, and we have the real life. And you see that, for example, the usage of Mitral in the world, in Europe, Germany, 40 patients per million inhabitants are treated with Mitral. Look at my country. It's one patient or two patients, blood like Greece, Spain, etc., a bit more than Poland. So there is a very large difference in terms of health economy, in terms of means, and these devices are extremely expensive, so we have to take care of that, and you know how we'll be able to handle it. Then we need a lot of equipment, and equipment is not there everywhere. This is not my cath lab. You saw a cath lab, here it's from Leipzig. And to be able to do this procedure in a proper way, you need fantastic cath labs. Look, it was an old cath lab in Leipzig, but we are expecting to have the same one within a couple of years. Many screens everywhere, all the pressure monitoring, the echo is there, fluoro is there, hemodynamics is there, you have pump, you have every equipment you want, very large and sterile room where everybody can work. It will mean a lot of money, a lot of means, and it will mean a reorganization. So now to conclude, dear colleague, first principle in percutaneous mitral repair, we should work as a heart team to post-indication and to perform. We have treating patients who are very sick, and we need to evaluate cautiously the cardiac status using echo, but also CT, and the extracardiac condition that's crucial. Edge to edge, the mitral clip is there, 30,000 patients. It is safe, it improves symptoms in selected high-risk patients, but we need longer-term follow-up, and we need randomized trial in secondary and also primary MR. The preliminary results of the direct ring annuloplasty are promising on these 50 patients. The transcatheter treatment after valve failure is promising, 500 patients, but we need longer follow-up. Transcatheter mitral valve replacement is in its infancy, but it's a very expensive baby, at $2.5 billion. In the future, no doubt, the respective indication of surgery and transcatheter will change. You know that now in Germany, for example, and at least in many countries in Europe, in the US, we are doing more TAVI than surgical arterial valve replacement. figure is not the same for mitral, but this will go the same way. And the change will occur depending on improvement in risk classification, careful evaluation of the result, and also refinement in technology. For example, there are more than 10 devices for mitral valve repair, more than 10 devices for mitral valve replacement somewhere in the pipeline. And finally, what is very important for us doctors is to change practice only based on evidence and not, I'm here as a device, I put the device in my patient. It is not the good way. And when we are changing the practice, we must carefully evaluate the consequences. So what happens in Germany? Germany, we should use it as an example of the future for many countries. Look, in Hamburg, we discussed Hamburg yesterday during the meeting. In Hamburg, 2006, 13,000 patients, and here in Germany, 30,000 patients treated with mitral regurg, and you see the mitral clip happen. First lesson, many patients are treated. It's good news, because you heard that a large number of patients were left untreated because they were felt to be too high risk by the doctor. So, increase in the number of patients treated, very good news for the patient. You see an increase in blue in the number of mitral clips. It is good news. But what is more striking is because these percutaneous devices are available, patients are referred. Patients come, and the effect of the presence, of the availability of this device is to increase the number of surgeries. The number of surgery you see here in red dramatically increased. So it's good for the patient. It's very good for the patient because now the patients are treated. That's very good for them. They are treated by less and less invasive surgery, either robotic or minimally invasive. That's very good. Or interventional cardiology. So thus the patients are really the winner. So we should be optimistic, but we should be realistic. Once again, I want to show you this slide. It is the example. It is a surgical gold standard. And Professor Carpentier, with the father of repair surgery in Europe and the world, stated the duty of any valvular surgeon today is no longer to correct the mitral valve regurgitation, but to correct it for the rest of the patient's life. So let's say that the standard is extremely high for us, but we should try very hard to improve the devices, to improve our strategy, and since I'm very optimistic, we can do it. So, thank you.
Thank you very much for a brilliant presentation. I have a question. One question is, do you use a femoral approach in all the cases, yeah?
Well,
can we use the left arm approach?
No. Well, for the mitral clip, there is no choice. You should use the transfemoral approach. For the annuloplasty, for the time being, there is only one approach. It is transfemoral, but all the devices are coming. And for example, we discussed about Professor Cook yesterday, I don't remember, during the dinner, because it was after 20 glasses of vodka and before 20 others. But,
so it's seven French, yeah?
Yeah. Some devices, it's 14 French. Some devices are coming from jugular. Some devices are coming from jugular. For valve replacement, most cases were done transapically because it 35-40 French for valve in a valve, valve in a ring. In our case, we mostly use transseptal, and others use transapical. So it is grossly the figure because the devices are very big. You can, but it's very difficult to put a 35 French device transeptally, but with time, the device will become thinner and thinner, just like for TAVI. For TAVI, we started with the big cuts, now you do percutaneous. It's completely different, so it's moving, but you have to learn transseptal. That's why I spent a little bit of time on transseptal catheterization. It is not a transseptal which was described 50 years ago, the transseptal echo guide.
And the second question, as I saw on Bichat, there was the feasible of two modular clip in one patient, yeah?
Yeah.
If it's completely dead patient, sorry. But you can clip two modular clip in one modular valve, yeah?
Absolutely. When you, in some patients, when you have a very important coaptation defect, or if you have quite a large prolapse, you can plan already to go with two clips. But in the other patient, you may start with one clip. And as I tried to explain, you put your clip where is a jet, and then you assess the result very peacefully. Your echo person look at the MR, look at the gradient, look at the pressure. If everything is okay, you stop with one clip. If you still have MR, you can come back with a second clip. You keep the guiding catheter in, you come with a second clip. Even you can come with 3 clips. We've never been up to 3 clips, but some people went up to 5 clips. Here the problem is the gradient. You should be very cautious. You should have exactly the same hemodynamics, have a good pressure, and see if the gradient is high, it's better not to release too many clips, but it is reversible. As long as you did not release the clip, you can catch it and you can reopen it and bring it back. So it is very, you can monitor very closely your procedure. But if you go for a patient, for example, with a very large coaptation defect, you may go with upfront with several clips. And the same price. That's very important. It is the same price. So 2 clips is, let's say, it's a bit less than half of the cases, but it's very frequent. 3 clips is rare, 4 clips is exception.
Thank you. Yeah. Thank you very much.
Спасибо большое. Пожалуйста, еще вопрос. I have one question. I know the cases you are doing cleaves, it's P2, 1, A2, you are doing cleaves in the regurgitation position for posterior to anterior. Or it is now possible to do cleaves with a commissural regurgitation?
Well, I didn't show that because it's really something which is explored. But there are people doing that. Even, I think, in surgery, for example, Professor Alfieri described the use of this technique to close commissure. And there are some cases which have been done, but we need reports. We need to see how long it lasts. We need to see the results published. But some people report cases of commissural prolapse. If you are planning to do a commissural prolapse, you need to be very experienced, and you need a different puncture site in order to adapt the height of your device. So it can be done in very expert hands. But to start, follow this line: central, localized, and not too high a product. But it can be done. I think Alfieri says, well, it's good, but Alfieri, in 99% of the cases, use also annuloplasty. So that's another problem. So and if you remember one of the first slides I showed, the Alfieri cases without annuloplasty, it goes down very fast. So let's wait. We have 5 years, which is good. We need more follows.
Okay, thank you very much. Еще вопрос, пожалуйста. Нет вопросов. Thank you very much. Then I will make a conclusion. I will say some words.
So now it's my pleasure to introduce Professor Рафаели, who is a nice surgeon, and we can speak with him. That's a pleasure, which is not always the case. So, and I cannot read the title of the talk, but as far as I understood from the program, we are going to discuss the long-term results of surgery.
The title is like that, the mitral regurgitation, view of surgery and endovascular surgery, what, when, how, and for how long time.
Okay, thank you.
Вы знаете, мне очень и было очень приятно, потому что вы уверены, что мы подготавливали наши доклады врозь. Я не был в Париже, он приехал заранее в Москву, но очень многие вещи я как хирург и доктор Vahanian как эндоваскулярный хирург смотрим, рассматриваем одинаково. Поэтому некоторые вещи, которые мы повторили, во-первых, это будет на родном языке, во-вторых, все-таки у нас школа повторение в отвечении. Итак, митральная недостаточность. Что, как, когда и насколько. Я скажу, что митральная недостаточность – это очень частое заболевание, как и было показано. И старше 75 лет больным людям может случаться примерно в 10% случаев. В Соединенных Штатах выполняется всего 50 тысяч операций. В Соединенных Штатах, где выполняется примерно 500 тысяч операций коронарных инфарктов. И посмотрите, частота хирургического вмешательства в зависимости от СТС, это риск смерти при 12% всего лишь 5,6% обнаруживается. На всех остальных людях остается хоспис. Перевод хоспис, это мы часто употребляем, а перевод все-таки не самая хорошая вещь, это богадельня, это приют. Вот эти люди обречены на такую жизнь. Итак, чтобы сделать хирургу и эндоваскулярному хирургу, конечно, надо представить, это было уже показано, митральный клапан. Это, конечно, это клапанное кольцо, это, конечно, сам осколок, это хортальный аппарат и папиллярные мышцы. Это первый порядок, который обеспечивает митральную функцию митрального клапана. И второй порядок – это левый желудочек и левый прицеп. Итак, понимание механизмов, обеспечивающих функциональную состоятельность митрального клапана – это единственная возможность, и это было прекрасно показано, понять причины биопатологии на этой основе, применить наиболее рациональную стратегию. И тут видно восстановление, исправление и лечение. Полную коррекцию мы достичь не можем ни в одних случаях. Мы можем чуть восстановить, исправить и лечить. Итак, адекватная запирательная функция и гениальность доктора Карпатес находится именно в том, когда он стал понимать, почему митральный клапан закрывается. И вот это закрытие, полное закрытие зависит от систолической силы напряжения подклапанного аппарата. Это сила, закрывающая створки, это систолическая сила левого желудочка и анатомическая целостность самого клапанного аппарата. Поняв это, только мы можем понять, почему получается митральная недостаточность. Итак, именно в зависимости от причин ее развития мы имеем первичную или доминацию митральной недостаточности, результат поражения одного из этих функций, аппарата митрального клапана, створки, хорды, кольцо, папиллярные мышцы, и вторичная или функциональная митральная недостаточность, когда при нормальном, это так красиво я сказал, клапан, в общем-то, чуть-чуть там все-таки створки поражены, есть определенные изменения, при нормальном клапанном аппарате является единственным следствием нарушения функции и геометрии левого желудочка. Это острый инфаркт, острый инфаркт миокарда, это кардиомиопатия. Итак, первичная митральная недостаточность причины – это увеличение хорд, растяжение передних мышц в сторону клапанного кольца. Вот все это приводит к тому, что кольцо возвращается в левый, митральный клапан столько возвращается в левом прицепе, получает митральную достаточность. Понимая это, основа патологии анатомических изменений самого клапанного аппарата, и в результате тактика фиксируется на восстановлении этого аппарата. Это клапаносохраняющие операции, это протезирование клапана сердца, и вот блестящие представлены эндоваскулярные процедуры по строгим показаниям. Как мы видим, показания все становится шире и шире, и это прекрасно, если вдруг представить, что у любого из нас может возникнуть митральная достаточность. Это операция, которую предложил профессор Рафаели, это схематически основа. Единственная, самая большая проблема, я вам честно скажу, я сегодня узнал, что эндоваскулярно можно сделать клапанное кольцо, поскольку я хирург, я не интересовался специально этим разделом, и это очень приятно. Вот эти операции, это иссечение створки митрального клапана, пластика и обязательно анулопластика. Это когда хорды удлинены, их можно уменьшить, и если они оторваны, можно создать артифициальные хорды, можно сдвинуть папиллярные мышцы, сейчас и даже эти операции делаются. Это то, что создал профессор Рафаели, и на этой основе стали эндоваскулярные процедуры развиваться очень быстро и отлично. Вот эти частота этих операций я не буду останавливаться, я просто скажу, что несмотря на то, что трансплантация охоты, искусственная и так далее, все-таки основные операции при любых состояниях